I welcome you all for this discussion of a course of CPCDM. Here we'll be discussing few clinical cases. There is not much theory. It is more of a practical implication because see what I believe, all those theories and all those lectures you can get anywhere. And now it is freely available on the YouTube also. So like whatever topic you want to listen, you can get the best of best faculty with all those theoretical part, right? All those guidelines are very well available, freely available on the internet now. There is no problem of those knowledge sources. But the problem lies when you have a question and that correct answer you want, that what we do, what our specialists do in those types of patient. So that is what we are going to discuss today. It is more of a discussion. So I want everyone, please on their cameras, switch on their video mode and keep on mute mode so we can discuss, because it's a session of discussion. Okay, right? So let's start with our first thing. First question, I put a very simple case which you will get, definitely you will get in day to day. These type of patient you see day in and out. Okay, so here we have case one, and feel free to ask and feel free to put your comments, because that is why what it will make this session more interesting. Because if you want answers to your question, you have to ask them, and those answer you are not going to get anywhere. Like even if you search too much things on the Google and PubMed, let's say, but the correct answer and the relevant and overall things and the accuracy of the data, all those are not there on Google, right? So please ask as many as question as possible. The session would last for around 1.5 hours. Okay, so we have here case one. First case, we have a 30-year male. Both the parents are diabetic. His BMI is 33. He has this acanthosis nigricans. Fasting sugars first time came as 116 and the PP came as 176. His HbA1c is 6.8. Okay, so here we have a young male with a family history, with obesity, with signs of insulin resistance, with sugars this much. This is for the first time. So what would be the choice of treatment in this type of patient? Please comment. Like what would you want this patient to give? Okay, Dr. Rupesh is saying metformin. Please put in as quickly as possible, then only the discussion we can move forward. Everybody agrees that we want to give metformin to this patient. Okay, Dr. Bala, lifestyle, LSM, okay, that's okay. Metformin, lifestyle, okay. So everybody has put a drug or lifestyle. Before that, I want to give you another question. Whether this patient, see, whenever you treat, whenever you treat a disease, you have to diagnose a disease. It's right. Up See, basically, when you treat, you have to diagnose. For that, you should know the normal. Then only you can say this is abnormal. Then only you can diagnose the disease. And then only you will decide the investigation. And then you will decide the treatment. So, whether this patient qualifies for being diabetic or not, first question is this. Everybody has put, okay, metformin, orlistat, and affording semaglutide. That's not the correct thing. Okay. So please tell me, do you feel that this patient qualifies as being called or being labeled as diabetic? Yes. So see, most of your answers are no, right? So when you see such type of patient, you cannot just start your treatment, right? Because there are n number of things. If you tell or if you write, if you diagnose this patient as being diabetic, you are actually changing many of the things. Firstly, the emotional thing, that is you're giving too much stress to the patient that now he is diabetic, which he does not qualify. Secondly, there is another medical legal part of it, because all those insurance things and all those may not be applicable now for this patient, right? So you cannot just label a patient as being diabetic. So anybody like why we are not labeling this, just on your camera and answer. So why you are not calling this patient as being diabetic, or what is the criteria you say that, okay, this is now a diabetic patient? To diagnose as diabetes, what is the criteria you follow?
ADA criteria, sir.
Okay. So what is that? What
Fasting
is
should be
the,
more.
yes? Okay, so we have here multiple answer. I'll give it due to lack of time. So most of you have answered it quite correctly, but not completely. So what is the definition? Definition is fasting being more than 126. So there is definition of fasting also here. The fasting should be of 8 hours. Okay, that is the requirement. Then postprandial, it's not exactly the postprandial, because see, post meal whatever he is eating, what is the glucose load, all those things changes. So it is 2 hour plasma glucose, that is what the ADA says. And ideally it should be done with a 75 gram of anhydrous glucose. But what you are getting in market is usually not anhydrous glucose. If you see, like what we use is usually the glucon D or something like that glucose, which has 100 gram has 90 gram of anhydrous glucose. Okay, so that means you have to correct it by 1.1. That means when you are telling that you have to give 75 gram of anhydrous glucose, actually you should be using 82.5 gram of another glucose. Or now some of the companies are getting even 75 gram of anhydrous glucose packets are there. So that is the criteria. Now that is a plasma glucose after 2 hours. So this post meal is actually not very accurate here. Thirdly, HbA1c of more than 6.5, that's a criteria. Okay, so maybe you will consider this patient as diabetic? No, because what the first thing you have to consider is that how this HbA1c has been done. The ADA clearly says that it should be done by an HPLC, which is the gold standard method. That is what we should be. Okay, so this 6.5 criteria is by HPLC method, and that is what is the gold standard method. You cannot diagnose by point of care machine. POC machine should not be used for diagnosis of HbA1c. So here we have not mentioned that. So it should be reliable. Now let's say, okay, it is reliable HPLC. So will you say that, okay, this 6.5, it is more than 6.5, so will you say that this qualifies for being diabetic? No. Again, the ADA says that two tests should be abnormal. Okay, now somebody said that, okay, a random sugar of more than 200 qualifies for being diabetic. Yes, that is a criteria, but that is along with symptoms. Okay, so these patients do not have any symptoms. So symptom with an RBS, random blood sugar of 200 qualifies for being diabetic. Okay, so this patient actually at present does not qualify for being diabetic. So you cannot just straightforward go and start all those semaglutide, metformin, all those lifestyle modification you need to do for this patient, because this patient has at least pre-diabetes for sure, and his BMI is 33. He has signs of insulin resistance, that is acanthosis nigricans, and he's a family history also. Okay, so another question here can be like, when will you repeat? Okay, let's say we have repeated the OGTT, HbA1c, and now this sugars comes as let's say 106, 145, and this comes by reliable method as, let's say, 6.1. Okay, so now this patient is actually a pre-diabetic and you have started lifestyle modification. Okay, so now when do you want to repeat the test? Anybody? Or a more easier question I'll put. Let's say you have given it a correct thing, and now let's make it normal, and it would be much easier. Let's say the fasting sugars comes out to be 99 after it was done. maybe the patient has drank tea and given his fasting sample, because when you say please don't eat anything, the patient usually drinks tea or coffee and then he says I have not eaten anything, and that history should be taken. So let's say that the fasting was 99 and the 2-hour plasma glucose came out to be 136 and HbA1c came out to be 5.4 by HPLC. So I made this question slightly easier. Now this is absolutely normal. Okay. I hope you know the normal cutoff. Normal is fasting less than 100, 2-hour plasma glucose less than 140, and HbA1c less than 5.6, equal to or less than. Yeah. So we have multiple answers, so you should follow the guidelines. The guideline says that if the OGTT and all those things are normal, even if this male has a history of family history of diabetes, the test should be repeated not after a year, after 2 months, like that. It should be repeated after 3 years until unless patient has symptoms. So we have here a 75-year male. Both parents are diabetic, and HbA1c is 31. Again, an obese patient with an acanthosis nigricans. Insulin resistance is there, and the fasting is 130, and the PP is 181, and the HbA1c is 6.8. Okay. So again, the same question, whether this patient qualifies for being diabetic or not, and what would you give as a treatment. Okay. Most of you are saying yes, he qualifies, and somebody wants to give metformin with DAPA. Somebody wants to give metformin alone. Anything else? Put in your chat box so that we can have a more lucid discussion, because these are the patient you will get in your OPT, and that's the session for today. That what you're getting in OPT and how to approach that patient. That is what we are discussing, right? Okay, very good. Dr. Rehan has actually given the correct answer. Everybody has told, okay, metformin, sulfonylurea, metformin, OHA, lifestyle. Okay. So now you see one correct answer we got. So I'll just end it here. So this is well controlled for age. That is what he have written, and that is correct actually. See, in our first case, this patient actually, even if qualifies, let's say this second case parameters were on the first case, that the fasting was 130 and the PP or the 2-hour was 181 and the HbA1c for 6.8. So this patient qualifies for being diabetic, and you can initiate with him a metformin, or even you can initiate with a dual drug also, because we have some data that along with an DPP4 inhibitor, that is the verified trial, showed that vildagliptin with metformin, when given directly at the initial stage, the chances of OHA being acted like a probability of adding a third drug decreases if you start both the drug at the onset rather than sequential, that you first give metformin, then you give vildagliptin, and then you add the third drug, versus you give a vildagliptin and metformin right at the beginning, and then you give later on a third drug if the sugars are not controlled, which would be like a, for a young male it would be HbA1c of 6.5. Okay, so if this was a 35-year or 30-year male, okay, so that is what the process is. But for this type of patient, though this patient qualifies, classically it qualifies for diabetes, but what are you treating? What is the target you are target you want? He is 75-year male. You don't want to make his HbA1c 6.5 or 6. If you make it even lower like 6, you are actually going to increase the mortality. Firstly, you have to understand, why are we treating diabetes? We are treating diabetes to control the complication. That is why we are treating. It's not okay ki sugars are this much, okay, let us make it normal. No. It is because we want to prevent complication. Even if you see how the cutoffs are derived. Okay, I'll tell you that also. Just a minute. So if you see that how the cutoffs are defined for everything, let's say creatinine or TSH or anything you talk about in this medicine, whatever the cutoffs are derived, that are from the Gaussian curve. That is that the 95% are taken as normal and lower and the upper 2.5% values are taken as abnormal. That is how you define normal TSH, normal creatinine, whatever you want. That is how the normal are derived. But here in diabetes, it is not how we derive normal. If let's say if you were doing like that, then the proportion of patient having diabetes would be always 2.5%, because that is what the patient will have the higher sugars. So your prevalence would be always 2.5%, but that is not what we do. Okay. So that is not true for diabetes. So how the cutoff for diabetes were defined, how this 126 came, that okay, fasting it is more than or equal to 126, we'll say as diabetes. So it came via data. We showed that beyond this, if the sugars are there, then the patient will develop complication, and that is what we are treating. Otherwise it would be always 2.5% having diabetes and your cutoff would change, right? But it's not like that. Similarly, for vitamin D, again, it is not how we define by the Gaussian curve. Otherwise, only 2.5% of the patient will have vitamin D deficiency, right? And 2.5 will have toxicity, something like that when you see the data. But it's not like that. For the vitamin D, what we did is the PTH level. At what level the PTH rises, that is what is defined as vitamin D deficiency. Similarly, at what level the complication increases, that is how you define as diabetes. So that this is the thing. So for this patient, because diabetes is a chronic disease, and this, if you talk about a 75-year male, he's not having that much time left for him to develop complication if his sugars are, let's say, 7 HbA1c. So this is well within target. What I would ask him is to manage only dietary, and even I would not want him to go on metformin, though he is diabetic, because he is well within control. What are we targeting, right? He's well within control. Okay. I hope that is clear. So lifestyle modification and diet is what I would advise for case 2. Now coming to case 3. We have here a 42-year male, and both the parents are diabetic with a BMI of 31 with acanthosis nigricans, and the fasting sugars is 116 pp's, 176, HbA1c is 9.1. So what do you want? Please comment on the in the this chat box. Okay, somebody wants to start a triple OHA along with insulin, combination of OHA. Somebody wants to start lifestyle plus metformin. Somebody is asking if symptoms are present. Let's say symptoms are not present. Look for the complication. Okay. So let's say no symptom, no complication. This is a young male, 42-year. By the way, there is no criteria for being called as a young diabetic, but usually we take cutoff of 40 years, but there's no such criteria. Somebody can say even at 42 also, somebody can say a 35 cutoff. Usually initially it was like 18 or 20 years were taken, and that was because the younger diabetic were more likely to have type 1 and older would have type 2, but nothing like that today. So young diabetic, there is nothing a perfect definition for that. No age is a perfect age for that, like a strict cutoff by any of the guidelines. Very good. We got an answer from Dr. Ravi Shah. Rule out the false high HbA1c first. That's the correct answer. That is what I was looking for. Because see, again, before you jump to treatment, please think, diagnose, investigate, and then treat. Okay. So we got that correct answer. Okay. So if you see here, the HbA1c is 9.1, whereas the fasting and post meal are not that high. So it is not corresponding to the HbA1c. Also, if this is the first report, this patient is still, you cannot say that this patient have diabetes, leave apart triple combination and insulin to start. HbA1c can be false due to various reasons, due to hemoglobinopathies, and due to multiple things it can go wrong. The method, the assay you are doing, usually there are 4 types of assays which we do. The best one is HPLC, then there is boron affinity, then immunofluorescence, then ion exchange, all those. So what method you have used, that is really important, and the patient can have this variation. So you cannot just jump to treatment, and especially in these type of patients who are coming for the first time, and there is no correlation between your blood sugars and HbA1c, right? So you cannot jump to triple combination and all those things. Okay, now let's slightly modify the question. Let's say this patient is already known diabetic. Okay, and now he's coming with this sugars, and he is, let's say he is on metformin plus dapagliflozin combination. He's taking metformin 2 grams per day and dapa 10 mg per day. Okay, so he's on this combination, and he's diabetic since, let's say, 2 years. Okay, so he's diabetic since 2 years with metformin, dapagliflozin, both parent diabetic, acanthosis nigricans, and now these are the sugars. So what would you want? Okay, very good. We got the answer right at the beginning. Third was correct. So we'll stop here. So check for compliance is the Dr. Tamal has answered, Dr. Tamal Burman. So that is the correct answer. That is what I want you to understand. Just when you see these patients in OPD, just think that his sugars are coming very good. So that means your drugs are acting, right? That is why his sugars are coming good. But his HbA1c is not good. So there can be 2-3 reasons for that. Firstly, the patient is non-compliant. That the patient is taking, let's say, once a week medicine. So when he got the test done, he took the medicine. Otherwise, he's not taking. So his HbA1c would be high because it's the average of 3 months in which 50% is of last 1 month. Okay, so this contribution of last 1 month is 50% in the HbA1c. So probably that is the reason. Or another reason can be that last month, like let's say now this last month was Diwali, so the patient ate too much sweets, and that is why his sugars at that time were somewhere around 300, 350, because he was eating day and night sweets, and now he's not eating, so his sugars are again normal. Now, in that scenario, if you increase the drug or if you introduce insulin, the patient will land up into hypoglycemia. So that is important to ask that what was his lifestyle, what is happening, or maybe the patient has just started the exercise and all those things previously he was not doing, and now the sugars are coming normal. Okay, so compliance, diet, exercise. Okay, so these are important thing. Another thing you have to ask, like whether he had some infection or not in the previous month. So maybe that is why, or maybe he received some drugs. And other than that, all those things we discussed previously, fallacies of HbA1c, that should be kept in mind before titrating, up titrating, down titrating, all those things. So in total, you have to be patient. Everything is important. Okay, so that is what I want to give message from this case. Okay, now we have reverse of this. We have a 42-year male, both parents are diabetic, HbA1c is 31, acanthosis nigricans is there, fasting plasma is 146, and PP is 256, HbA1c is 6.3. So what do you want? No, no, he is non-diabetic. Dr. Ravi is asking like whether he took the drug. He is diabetic. He came with this first-time report with an HbA1c of 6.3, with a fasting of 146 and a PP of 256. Okay, that is okay. That most of you have told that check HbA1c whether it is reliable or not, and hemoglobinopathy that we have discussed. Obviously, that we are going to do, but what is more important, I put the question this way so that from each question you learn something. So again, whether this patient qualifies for diabetes or not. Okay, great. Everybody is saying yes. Somebody against that, okay, this patient does not qualify for diabetes. Let's say this was an OGTT. Okay, so yes. everybody of you is correct. No, it's not pre-diabetic. Somebody wrote pre-diabetic also, but this patient actually qualifies for diabetes if the tests were done accurately. All those things we discussed, I'm not repeating all those, that we have done it in correct way, as and all those things I've discussed in first case. So why this discrepancy? This discrepancy may be obviously with all those things we have discussed. Another thing I want to discuss, in a recently diagnosed diabetic, your HbA1c can be normal. Okay, because this is showing a control of 3 months. Okay, so these type of patient you get in your OPD where your fasting is high, PP is high, and your HbA1c is low. So rule out all those things previously discussed. And this patient actually qualifies for being called as diabetic because two tests are abnormal, and this patient should be started on treatment. And then you have to see, because if you don't see, like his HbA1c will keep on rising. Maybe it is not in that range at present, and also in during those ranges in middle, the HbA1c is not that accurate. It may be normal in some patients who are diabetic, whereas it may be slightly higher, even going beyond 6.5, who are pre-diabetic. Okay, so that you have to see in clinical scenario as well. Okay, now we have another question. We have here 35-year male on medical nutritional therapy for diabetes. So he's not on any drug and he does not have symptoms, but he's following diet because he was diagnosed as type 2 diabetes. Okay, previously. Both the parents are diabetic. BMI is 41. Acanthosis nigricans is present. So fasting plasma glucose is 122. And postprandial is 208. And HbA1c is 8%. Okay. So what do you want to give him? So again, I'll repeat. We have here 35-year-old male type 2 DM on dietary modification for diabetes, 41 BMI, fasting is 122, and postprandial is 208, HbA1c is 8. Whether you want to continue the same, you want to add something, you want to give him something, and let's say he's compliant to the this diet. He's not eating all those sweets and everything. So we got answer as some answer is saying OHA plus insulin. Which OHA would you want to give, Dr. Priyanka? Then we have sulfonylureas. That is not actually correct. You don't start with this type of patient. You don't want to give actually sulfonylurea right at the beginning. Dr. Umesh, which dual therapy would you like to give? Metformin and SGLT2 inhibitor, Dr. Tamal. That's, I take it as a almost correct answer. That is a good option. Then metformin plus DAPA. Somebody, like most of you have written dual therapy, but you are not mentioning which dual therapy you want. Okay, Dr. Nasruddin, you have written metformin plus lifestyle. He's already on lifestyle. So that is what I want to discuss, that metformin alone will not work in this patient. The reason being, if you see, he's a 35-year male and the target HbA1c, what you want for him is something around 6.5, right? So your metformin will not make it to 6.5. That is why a single drug is not of much use. And Dr. Ravi has actually given it answer, very correct answer almost. So metformin plus another therapy and a semaglutide would be preferred in this type of patient until less contraindication is there. And that way this patient will actually lose weight, because if you see, he is in criteria of morbid obesity. In fact, he is in criteria of bariatric surgery. So this patient can be even given an option of bariatric surgery, which may even reverse his diabetes. So that's a good option for him. Otherwise, oral GLP-1 analog is good enough. Injectable GLP-1 analog with a metformin is good enough. Patient not affording for this, then you can actually give him a SGLT2 inhibitor. That is good enough. But sulfonylurea, I would not prefer in this type of patient, because you will again make this patient more obese, because that this patient will gain more weight, right? So that is not what we want for him. He's already 41 BMI. Do you understand what is the complication of this? He's just 35 years. With this BMI, he is more likely to develop hypertension, more likely to develop obstructive sleep apnea, hyperuricemia, gout, sexual dysfunction, respiratory reserve would be less, GRD would be more. Later on, he'll more likely to develop osteoarthritis, right? So all those things, and cardiac disorder, all those we are predisposing. So his weight should be actually taken, and this patient can even have reversal of diabetes. Okay, so reversal and remission we'll be talking about later, but let's first discuss this question. So metformin, you should be giving this patient in full dose. Okay, along with that, a GLP receptor analog. Okay, so GLP analog is something which I would prefer. So just for those who are not practicing, I'll just tell them that we have two types of GLP-1 analogs. Either we have injectable or oral. Oral comes by the name of Rybelsus. Okay, so here this is first time a protein molecule is given as orally. There are some snack thing is there in this tablet which causes this protein is not degraded in the your stomach, and it is absorbed because there one local alkaline media is made by that snack. And this medicine comes in three strengths at present: 3 mg, 7 mg, and 14 mg. So you have to give this as a fasting. Fasting means absolute fasting without even water before that. So that medicine should be not, it should not be chewed, it should be swallowed with 120 ml of water right in the fasting state, and half an hour there should not be anything including water. The patient should not be taking even water for half an hour. And this 120 ml is derived again from a study, because at this level the absorption of this drug is maximum. So it's like a half cup of water. You have to ask your patient, take empty stomach this medicine, and then half an hour later you can do whatever you want. So this is how it is started, and every 4 weekly the dose is up titrated. Now injectable comes as weekly injection or daily injection. Daily injection is liraglutide, which comes by the name of Victoza. Weekly injection is dulaglutide, which comes as the name of Trulicity or Aplivent. Actually, it is produced by Trulicity only, but it is in India. It is also marketed by Lupin by the name of Aplivent. Okay, and this Victoza is by Novo. This Trulicity is by Lilly. Okay, so these are the companies which are available in India. So for Trulicity, what we start is 0.75 mg weekly injection we give, and once a week injection is given like an insulin. I could not show you the demo, but it is you can search on online also, you'll get it. So once weekly, it's a syringe where there is a lock system, and the patient is asked to inject. The whole drug goes inside. There's a sound of click through after which the drug is injected, and again a second click comes. That means the drug is completely injected. It's a use and throw pre-filled syringe. Okay, and if not taken weekly, like let's say the patient has forgotten, he was to inject on Monday, so he's not injected on Monday, so he can inject on Tuesday, Wednesday, or Thursday. At least there should be gap of 4 days between the two injections if he's forgetting one dose. That is what the product monograph shows. For Victoza, we start with a lower dose, that is 0.6 mg, and we go up to 1.8 mg. That is what is the maximum dose can be delivered. There is a dial which on which it is written 0.6, 1.2, and 1.8. Okay. Now there is another liraglutide which is approved for obesity, which is not actually this Victoza injection. That is Saxenda. That is not available in India. So here up to 3 mg dose can be delivered. Okay, so these are the drugs because we want this patient to lose weight, and liraglutide is actually approved as an anti-obesity, not at this dose, but yes, it is approved and can be given. But that's a theoretical thing because in India it is not available. Sometimes we obviously give Victoza twice daily injection sort 1.2 and 1.8, but that again it's like we do give, but it's not typically written anywhere. So these things you can do for these patients, and actually by losing weight, you may reverse the diabetes. Okay. Now let's talk about anybody. Is there difference between reversal and remission? Anybody has any idea? See, somebody has asked, given the option of metformin and gliptin. That is also okay, but gliptin is actually weight neutral. The patient will not lose weight. Somebody has written rapaglinide as the PP is high. That is okay, but rapaglinide is a secretagogue. It will again cause weight gain, and that is not what we want in this type of patient. Okay, and somebody has written SGLT2 inhibitor. That is a third choice. I have taken well. Somebody has written a gliptin and a GLP-1 analog. So it is not to be given together. That should not be given. Okay. Somebody has given that remission is 6.5 and reversal is 0.7. No, that is not a correct answer. Anybody? You can unmute yourself and we can discuss also. So is there any difference, or reversal and remission are the same? Because that is what I would prefer for this patient. I believe there is a like a typing error with Dr. Uh, Datta. He has written remission is still diabetic with drugs, remission in patient, and probably he's written both the times remission. Remission means disease is cured. Dr. Priyanka, that is actually wrong. Okay, so without wasting time, I'll tell you. See, these terms are actually used interchangeably, but there is just slight difference between the two. So reversal means that the sugars are controlled without medication on dietary control. That is reversal of diabetes. Remission means when the sugars are controlled for at least 3 months without medication on diet. That is what is called remission. Cured is like cured, the disease does not recur. Okay, so it goes into remission. Reversal is at that point of time, and may after 3 months you can call this as remission, but in general both the terms are used interchangeably, but that is the technicality between the two terms. Okay, you want me to repeat? There are two terms: reversal of diabetes, remission of diabetes. Both in general are used interchangeably. There is not much difference, but if you go into like a more scientific type of definition, so reversal is like, let's say I have a sugar now, I reduce weight, and now my sugars are okay at the just now it is okay. So this is reversal of diabetes. Now, if my sugars are controlled on diet only without I'm not taking any medication for next 3 months, then I can be called that my diabetes is in remission. So this is basically remission is a point is a duration after which you will call it remission. Reversal is just at that time the sugars are controlled. That is what is reversal. Okay. Okay, now we have case 6. We can just move forward fastly because we are running late. So we have here 23-year male, both parents are diabetic, BMI of 23, 23, PP is 223, HbA1c 9.2. So what do you want for this type of patient? So what is your diagnosis? Okay, so we have many answers, and most of you actually have put your bets, and that is good. So see, again I'll say, before treating, just don't jump to treatment. That is what all of us are being doing because nobody taught us that way, right? So what as soon as you see some blood sugar, you start medicine. And even I see few endocrinologists writing this gliptins on those patients who have history of pancreatitis, because you don't ask your patient, right? That is the problem, that you don't give the time, you don't think about etiology, you just without seeing, just you label as okay, this is type 2 DM. No, here I've specifically given 3 4 pointers where you can make a diagnosis, right? Because this is a young patient, 23-year male, okay, with a family history, with a near normal BMI, okay, and he is diabetic. Okay, diabetes means blood sugars are raised, but it is not type 2 diabetes. It can be anything. It can be type 1 diabetes, it can be MODY, it can be pancreatic diabetic, it can be syndromic thing, it can be secondary diabetes. So you have to ask all those history. That is really important. You have to look for all those signs. And then you will decide, okay, what is the best treatment? Let's say the patient has history of steatoria. I do understand that probably you know what is steatoria and how to ask history. Okay. So if let's say this patient have steatoria, so you cannot give this patient gliptin. That's a contraindication. And that almost every month I see a prescription. Okay, so all those things are really, really important while you address. So what is the approach? First, you have to see the history. In history, not only about this, all those that this is at this point time his weight. Okay, BMI. Let's say before this his BMI was 32 and now he's losing weight and he came at 23. So probably it's type 2 diabetes only, right? So all those things are important. You know, you should ask in toto everything about all this history you need. Your pedigree you need, three generation history you need for MODY, but that may not be always present. In somewhere around 5 to 10%, that would be negative. Okay, then examination, you have to look for signs of insulin resistance. Okay, so here I have not put that. So see that whether the patient has acanthosis or not. That is important. Skin tags or not. Whether the patient has stria or not. Proximal muscle weakness or not. Whether the patient has symptoms of acromegaly, signs of acromegaly. Whether the patient have that steatoria or not. So that is important. And then you jump to all those things investigation. So what most of us did is directly started with treatment, which is absolutely wrong, and others started with investigation, that C peptide and GAD, right? So that is again wrong. First, please, the golden rule of medicine is history, examination, investigation, followed by treatment. You cannot reverse it. Okay. So again, history is important. In that only you will sort most of the thing. Then examine your patient and then you decide which investigation you want. Okay. So C-peptide, GAD antibody, and CT abdomen for pancreatic calcification, or you may just get an X-ray also. X-ray abdomen erect AP view is good enough. And for the MODY and all those, next generation sequencing or Sanger sequencing if already the gene is known. So that is how you should keep an approach towards young diabetes. It's not that you see the sugar, label everyone as type 2 diabetes and start treatment depending on sugars. No, that cannot be done. Okay, so this is the difference I've just put between the three, but there are a number of causes for this. So let's discuss very shortly. So age is not a bar, but usually type 1 are younger, but even at 65, you can have type 1. Type 2 are usually elder, but you can have at 12 and 15 years also. But so this is not a strict cutoff. Okay, if a younger patient will come, then only I'll think about type 1. If an elder will come, I'll not think about type 1. No, it's not like that. Then MODY, usually the age of presentation can be anything. Like a patient presented you after 10 years. Now he's 40, right? So it is when he's presented you, it's different, right? Onset is usually less than 25. But again, it's not a strict rule. Then weight, due to increasing obesity, even we are seeing type 1 obese diabetes. So again, that's not a strict thing that, okay, you see a obese patient and it cannot be a type 1. No. So usually thin, but they can be obese. Type 2 are usually obese. And very important, there would be stronger family history for type 2 rather than type 1. Okay, autoantibodies are present only in type 1, but 5 to 6% can have GAD antibody in general population also, but usually it is considered as a marker of type 1. Okay, insulin dependency, it's obviously type 1, but later on to have insulin dependency. Insulin sensitivity, it is normal in the body and type 1, but in type 2 it is decreased. But in type 1, when the sugar too uncontrolled due to glucose toxicity, there can be decreased, and also because the patient can have obesity along with type 1, then maybe their insulin sensitivity may be decreased, but in general we consider that this is normal. Okay, family history, I've all told you that 2 generation for the body, more frequent for the type 2, and type 1 also have a history, but it is lesser than the type 2. Risk of ketoacidosis is higher in the type 1, but what you see mostly the patient of type 2 because of the increased prevalence. So it's not that if the patient have DKA, then it is type 1 only. Okay, because mostly what you're seeing DKA is actually type 2. Okay, so there are no strict pointers that okay, this will make this patient as type 1, type 2, MODY, acro, all those. Even secondary diabetes is presenting as a young patient, let's say 20, having DKA and later on diagnosed to have as pancreatic diabetes. Also, one important clinical thing I want to tell you here, that if you see any elderly patient, like let's say 75 years, who is presenting with high sugars, or let's say who is presenting for diabetes, please think about pancreatic malignancy. That should not be missed. Okay, so that is important. So all those things you have to consider: your history, then your examination, all those signs should be taken into consideration. Then you should decide which is the best investigation, or you can do a stepwise investigation. Okay, this is the probability this patient is high, so will I do this investigation first, and then you should decide treatment accordingly. Okay, so now we have here case number 7. So we have here 44-year male, both the parents are diabetic, and yes, LADA can be thing. LADA is something which is between type 1 and type 2. It is also called as type 1.5. He patient initially behaves like type 2 and responds to OHA for more than 6 months and even up to 6 years also, but usually the median time is around 3 years, after which the patient requires insulin, and these patients are antibody positive. The most common antibody is GAD antibody. Initially their C peptide is normal or high, but later on their C peptide is low. So it is the spectrum is between somewhere between the type 1 and type 2. Okay, so yes, it is a possibility. LADA is a possibility. So that's how we diagnose LADA. Okay, so here we have a 44-year male, 31 BMI with a fasting of 188, postprandial of 344, and HbA1c of 11.4, and he is not on any treatment, first time presenting to you. What would you like to do? Okay, Dr. Yashir want to start insulin. Dr. Mahan want to start a GLP-1 receptor agonist with metformin with a SGLT2 inhibitor. Somebody wants to send a C peptide. Okay, so most of you are in favor of insulin. Okay, that is what the guideline says. With that, these high sugars, you have to initiate insulin. But if the patient is not willing and the patient is drug naive, you can even start with a triple combination, and we see patient responding very well. But the ideal scenario, especially if the patient have catabolic features, you have to initiate insulin. Okay, and C peptide I would not prefer at this stage, because of very high sugars, sometimes the C peptide can be falsely low. Okay, so please don't get C peptide at this time. Also, I believe you don't need it, because this is a classical type 2 diabetes whose both parents are diabetic with signs of insulin resistance. You have acanthosis nigricans, BMI is high, so his C peptide should be high only. At present, we don't need his C peptide. If you want to confirm and do it, but I believe it is of not much use. Okay. So yes, this patient requires insulin. That is what the guideline says. All those how to initiate, what all to do, because last time in CPCDM we have a session on insulin almost for 2.5 hours. So I cannot discuss all those things within short span. So we are just skipping how to initiate all those things, right? So we have here case number 8, who is 35-year male, whose fasting glucose is 130, PP is 202, his HbA1c is 7.8, and his EGFR is 66. Okay, so I've added a component of EGFR here. So what do you want? And let's say you have ruled out everything and he is type 2 diabetes only. Okay, okay, Dr. Balaji wants to start metformin with an SGLT2 inhibitors. Okay, most of you are writing metformin with an SGLT or metformin with a DPP4 inhibitor. Let me make this question slightly more tougher. Let's say the patient's HbA1c is not that high. It is 6 point, let's say 8. Okay. Now what do you want? Still, do you need a dual therapy, or you be satisfied with a single drug? And he's drug naive. First time coming to you, and classically he's diabetic. His fasting is above range of the diabetes diagnosis. PP is 202, again a diabetic diagnosis, and his HbA1c is also 6.8. Okay, I got the correct answer. Yes. So still you want to start an SGLT2 inhibitor. That is what the answer I was looking for. Actually, what you are saying, Dr. Priya, HbA1c is not reliable in CKD patient. I agree, but that is at like very high creatinine. This is pretty okay. EGFR 66 does not like, even you can give metformin at this. Okay. So if the patient is obese and is eating, it is classical type 2 diabetes, and you need to give a SGLT2 inhibitor even if your sugars are controlled, because that's the classical thing. Even now we have now that just now on 4th of November we have data for EMPA kidney as well, and previously we have data for DAPA CKD trial, which showed that the doubling of time requirement of dialysis, renal replacement therapy, renal transplant, all those things are delayed with an SGLT2 inhibitor. So this patient actually qualifies that you should be giving even in non-diabetic kidney disease. Now we are giving this drug. So leave this. This patient is diabetic. You have to give a SGLT2 inhibitor. Okay, until unless like he is having, let's say, recurrent UTI or all, you have to give a SGLT2 inhibitor. Okay, so that is why I put this question. Now coming to question number, this I have already discussed, like 6.5 HbA1c with a fasting 112 within, like his sugars are controlled and he's already on metformin, but still you need to give a SGLT2 inhibitor. Now let's talk further. The patient is on metformin 2 grams. His fasting is 112. His post meal sugars are 177. His sugars are pretty controlled. He's diabetic. He's on metformin. And now his EGFR came as 28. So what do you want? Okay, so you want to stop metformin, that is okay, and you want to start insulin. Dr. Shashank want to reduce metformin. He's on 2 grams, like you want to make 1 gram. Somebody wants to stop metformin and start linagliptin. Somebody wants to start empagliflozin. So from these answers only, I'll pick 2-3 questions and I'll tell you. So somebody wants to reduce the metformin. So at what level will you stop metformin? And at what level you will continue metformin, and what the guideline says? My first question is that. Secondly, somebody told you can give EMPA. So at what level of eGFR you are happy to prescribe empagliflozin? Thirdly, somebody wrote linagliptin. So at what eGFR you can give linagliptin, and his sugars are controlled. So when do you want to start insulin? So these are my 3-4 questions. From the answers given by you, I have asked 3-4 questions. Okay, somebody wrote at eGFR less than 45, you have to stop metformin. 30 to 45 decrease, don't initiate. Okay, Dr. Ravi Shah has actually given a very correct answer. AMPA up to 20 and DAPA up to 25. Lina can be given in any eGFR. That is well taken. Okay, so basically what the guideline says, metformin can be initiated in eGFR more than 45. If the patient is already on the metformin, you can continue up to eGFR of 30, but less than 30, you have to stop metformin. So this patient ideally should be not on metformin. There is nothing of reducing the dose of metformin. And also the upper dose at which you can give metformin is up to 4 grams, but below 30, you have to stop. Okay. So this patient should not be metformin. Coming to insulin, you actually don't need insulin in this patient because the sugars are pretty controlled and you don't want a further drop in HbA1c. That is well taken. You have to give dapagliflozin or empagliflozin. Okay, whatever you want, you can give. So this patient should be given an SGLT2 inhibitor because this will prevent further renal worsening irrespective of his diabetes control. Okay, so the question was whether it can be given below 30. Yes, it can be given. Now we have trial where DAPA can be given up to 25, AMPA can be given up to 20 eGFR ml per minute. Okay, so these are the lower limits where you can actually give, and cannot, it should be given, I would say. There is nothing called can be given now. This patient should be given. Okay, now coming to our last case. So we have here 35-year male on metformin 1, and his fasting sugars are 116, PP is 136, HbA1c is okay. Linagliptin, there is no added advantage of giving linagliptin in our previous case, okay, because his sugars are well controlled. You can give linagliptin, but see, why are you treating diabetes is to prevent complication. This complication of what he is already developing, maybe it is a diabetic kidney disease, maybe it is not a diabetic kidney disease, because we don't know, we don't have much history here that okay, he was diabetic since this, what was his control. At present, you need to give him a SGLT2 inhibitor. If the sugars are well within control, with that, there is no added indication of linagliptin, or linagliptin would not help him in extra thing. And also you are unnecessarily going to increase the cost, because the cost of linagliptin initially it was somewhere around 42, still it is high, somewhere around, I believe, 30 rupees is still the cost. Okay, Dr. Ryan, that only I'm telling you, even if the sugars are controlled, he needs SGLT2 inhibitor. Now the KIDGO guideline says that those who are DKD, CKD, they are benefited with an SGLT2 inhibitor. Okay. Coming to our case number 11, we have a 35-year male on metformin 1 gram with a fasting sugar of 116, PP of 176, HbA1c of 6.8, and he has a history of coronary artery disease with an heart failure with reduced ejection fraction of 35%. Okay. So most of you have written it correctly. We need to add a SGLT2 inhibitor. That is what the guideline says. And what about metformin? Do you want to continue? Do you want to stop? Do you want to increase? What do you want? Okay, there is a good question regarding Finrenon. I'll cover that also, and I'll tell you about the Fidelio and Figaro trial also. Okay, so most of you want to continue metformin, that is correct. Initially, we used to think that it is not, it should not be given in those patients who have heart failure. And then came the data that okay, you should not give in the grade 3 and grade 4 NYHA, class 3, class 4. But now it is not like that. You can give in patient with heart failure. In fact, there is some data which shows that it may be helpful. So you have to continue metformin and you have to add an SGLT2 inhibitor. So these are the latest guidelines I've taken from ADA. If you see here, that is how we go about in all these patients. So first line therapy is obviously lifestyle modification followed by metformin. Then you assess whether the patient has ASCVD, atherosclerotic cardiovascular disease already established or having high risk. By high risk, you mean like the Indian ethnicity, high age, smoking, hypertension, dyslipidemia, or even urine microalbumin is considered as an high risk ASCVD. Established ASCVD, whether the patient has already passed MI or past stroke or past peripheral arterial disease, it is established ASCVD. In those patients, independently of the HbA1c, very important, independently of HbA1c, you have to give these three drugs, these two drugs, either a GLP-1 analog or a SGLT2 inhibitor with the proven CVD benefit. That is what the guideline says. So GLP-1 analog we have already discussed, but a catch here is कि oral GLP-1 analog, semaglutide, still do not have very robust data for the CVD. It was neutral. 3-point MACE was neutral in all those pioneer trials. Specifically, it was the Pioneer 6 trial for this. Okay. Pioneer 6 trial was for the oral semaglutide, whereas the injectable semaglutide, which is still not available in India, which comes by the name of Ozempic. Okay. So that is not still available in India. So that sustained 6 trial that showed benefit. So now we are moving for another trial, that is sole trial for the oral semaglutide, that is Rybelsus. After that, you may say that okay, it is a proven CVD benefit, but at present it does not have the oral semaglutide. Okay, so you have to give either an injectable GLP-1 analog or an SGLT2 inhibitor. But if the patient have heart failure with reduced ejection fraction of less than 45%, then it is you have to give a SGLT2 inhibitor irrespective of what is the diabetic control, or even if the patient have diabetes or does not have diabetes. Okay, coming to same way, if the patient have albuminuria and CKD with an eGFR more than 20 or 25 for drug we have discussed, you have to give a SGLT2 inhibitor. Other than that, if the patient have some contraindication, you have to omit that drug. So like even those patients who have pancreatitis should not be given a GLP-1 analog. Those patients who have history of MTC, okay, that should not be given a GLP-1 analog, medullary thyroid carcinoma, because there are some rat studies which show that can increase the chances. Those who have recurrent UTI should not be given an SGLT2 inhibitor. Okay. Similarly, like if you want those drugs which have a lesser hypoglycemia, you have these two. Along with that, you have a DPP4 inhibitor, which is very good and a weight neutral drug. And then if you have want an obese patient to lose weight, we have already discussed that we'll prefer a GLP-1 analog followed by an SGLT2 inhibitor. Metformin should be before that. And if cost is a major issue, now we have this various drug almost at equal cost, leave apart the GLP-1 analog. Otherwise, cost is not an issue for, because in India we get all those drugs at the same cost, but in other countries the SGLT2 inhibitors are still not available. The other brands are not available. Okay, so that is how you treat diabetes. I have given few clinical cases. Hope that this makes this session interesting. So thank you everyone who has joined in for the session. I hope this was useful for you, and I tried to involve as many as practical aspect as possible, because I believe all those theoretical points are discussed by everyone, and you would have heard and read a lot about everything, all the drugs and all those things, but how actually we do it on the patient, that is what I want to discuss with you.